كده واضحة السكرين إن شاء الله؟
اتفضل يا دكتور.
شكرا. بسم الله الرحمن الرحيم. My talk today is about conditions in renal diseases. This is a symposium sponsored by Nestle Health Sciences, but the scientific content is away from any commercial items. My agenda will include 3 points: the considerations of nutrition in nephrotic syndrome, in urolithiasis or urinary tract stones, and in chronic kidney disease. I start by the nephrotic syndrome. We all know that nephrotic syndrome is consists of proteinuria more than 40 milligram per meter square per hour, hypoproteinemia, edema, and hyperlipidemia, with the famous edema of the eyelids and lower limbs, and even in some cases ascites and scrotal edema. When we come to the dietary recommendations, we find what's written in the Comprehensive Pediatric Nephrology textbook, 2008. It states that maintenance of protein intake at approximately 130 to 140% of the recommended daily allowance for age. So we have to increase a little the protein intake to compensate for the loss in urine. Avoidance of saturated fats, because as we mentioned, there is hyperlipidemia, so we avoid saturated fats. 2016, another textbook, Pediatric Nephrology, said that salt restriction is advised for prevention and the treatment of edema. And fluid is not restricted unless there is plasma sodium less than 125 milliequivalent per liter. Otherwise, fluid in a normal amount or even slightly in excess is recommended because there is thrombotic tendency. Carbohydrates should be given preferentially as starch or dextrine maltose, and avoid sucrose, which increase lipid abnormalities. This year, there is a pediatric nutrition from the American Academy of Pediatrics, which emphasizes sodium restriction and serves to palliate for symptomatic edema. Restriction of dietary fat, again, to 30% of the daily energy intake. And it highlighted another point, which is steroid-associated obesity that occurs in these cases, because as you know, the corticosteroids are the mainstay of the treatment. So steroid-associated obesity is important to avoid avoid rapid weight gain and careful weight monitoring. So in summary, we have to modify water intake, no restriction, even excess, except with low sodium. Carbohydrates, no restriction, avoid sucrose. And also we have to remember that steroids sometimes cause steroid-induced hyperglycemia. And so we might not increase this carbohydrates too much. Lipids, restrict for saturated fat 30% of energy intake. Proteins, 130 to 140 of recommended daily allowance. The low sodium is important for the edema, for control of blood pressure, and for the salt and water retention effect of steroids. And we have to give calcium and vitamin D supplementation because of the steroid effect. Congenital nephrotic syndrome is a special situation where we have to give protein supplementation more than 4 grams per kilo per day, because there is a huge amount of proteins lost in urine that might reach up to 10 grams per day. We have to give lipid supplementation to give enough energy and maintain growth, and vitamin A, D, and E, and soluble water, soluble vitamins, calcium, magnesium supplementation, and all this may be given either oral, but in many cases, nasogastric or even gastrostomy route may be needed. Now we come to renal stones. What about nutrition in renal stones? We all are acquainted with this slide, where we have high oxalate. We restrict greens like spinach and celery, okra, but the important, always forgotten, cocoa and chocolate, berries and nuts, tea and coffee, all these high in oxalate. Uric acid stones, we restrict the high protein diet like meat, high purine diet like meat, particularly visceral, meat extracts, anchovy, shrimps, and for the greens, cauliflower, lentils, and kidney beans. This is well known. but usually forgotten the fluids. The fluids are very important to dissolute the salts and even the stones in some instances, and we have to give 2 liters per meter square per day or more. But the most important is not the amount taken, but the amount of urine excreted. So we have the urine color chart where we can see the degrees of yellow discoloration of urine. So we have to keep the patients with these 3 colors. What about the source of water? Does it differ? Usually, the patients and the parents are afraid of the mineral water. Does it represent a problem? It is high or contains some amount of calcium, magnesium, sulfate, iron, sodium, zinc, potassium, and chloride. But we can say that the magnesium and calcium and mineral water improve urinary pH output as well as oxalate excretion. And it's the amount taken with this mineral water of calcium and magnesium is far below the recommended daily intake. So there is no danger with mineral water. But we have to remember other fluids. As we mentioned, dark soft drinks tend to contain oxalates, and caffeinated beverages are dehydrating. So we have to take a cup of water after the cup of coffee. And it contains also phosphates, which link to higher kidney stone recurrence. The sugary drinks tend to alter calcium and magnesium absorption and increase the risk of kidney stones. Proteins is risk of kidney stone formation greater with the animal than vegetable proteins. And the sugar, kidney stones are associated with high sugar intake, and the effect of sugar consumption is through increased insulin secretion, which result in increased calcium excretion by the kidneys. Fibers are protective because they combine with calcium in the intestine, prevent its absorption, and hence its excretion in urine. And this is an old study, 1993, that proves that a high dietary calcium intake decreases the risk of symptomatic kidney stones. Sodium, calcium and sodium compete for reabsorption in the renal tubules, and so excess sodium intake will result in loss of calcium in urine and hypercalciuria. While potassium is the reverse, it's protective. And in a study of 45,000 men with high potassium intake, they have been protected 50% less likely to develop kidney stones. Magnesium is like calcium, it's protective, it binds to oxalate and acts as inhibitor for formation of calcium oxalate crystals. Vitamin B6, 10 milligram per day, lowers amount of oxalate in urine, and in high doses, it's used in treatment of kidney stones. And thiamine deficiency is associated with stones. Vitamin C in high doses, more than 1 gram per day, causes hyperoxaluria. This is well known. But this is a study in 1994 that proved that high amounts of vitamin C from 5 to 10 grams per day didn't show an increase in oxalate in urine. The reverse was proved in this study's case report, where vitamin C-induced hyperoxaluria caused reversible tubular interstitial nephritis and chronic renal failure, which is case report. So the vitamin C should be taken cautiously and not to exceed 1 gram per day, which is safe. Citrate acts as inhibitor to stone formation, is very well known. The magnesium citrate salt is used for treatment of many stones. It's provided by lemonade. The vitamin C content in lemonade is not that high and should be considered with other sources of vitamin C to prevent the increase in vitamin C intake and hyperoxaluria. The orange and carrot juices also are high in citrates. So in summary, for the stones, we can give excess water for both types of oxalate and uric acid. Carbohydrates should be decreased. Lipids have no role. Proteins decrease, mainly the animal. The sodium, low sodium, more potassium, calcium, and magnesium are recommended. Vitamins high B6 and B1, and low C for oxalate. Fibers and citrate in high amounts are protective against stone formation. Now I come to the third part of this talks about the chronic kidney disease. Chronic kidney disease have been classified into stages according to the GFR. The lower GFR, the higher the stage. And in this table, it's classified into 1, 2, 3, 4, 5. And we have to add this sixth stage, which is the 5D. It means patients on dialysis, because this term will be used in the recommendations right now. The metabolic role of the kidney is well known, but we have to revise to see the problems that we're going to face in the nutrition. It has to eliminate waste products of protein metabolism, eliminate potassium, phosphorus, and has multiple roles in calcium phosphorus metabolism, correction of acidosis, correction of anemia, and most important, the fluid balance. Now we come to the recommendations, the nutritional recommendations for patients with CKD. For the carbohydrates, there is no guidelines regarding the amount of carbohydrates should be taken, and also for the fat. But there is a small recommendation for the cardiovascular guidelines about the omega-3 fatty acids, which may be a protective, cardioprotective in these patients. The most important guidelines, and nearly the only guideline, is the KDOQI Clinical Practice Guideline for Nutrition Children with CKD 2008 update, and it's published in 2009. In this recommendation, we can find the following. Number one, about the energy requirements and therapies. This is very important as it represents the base for what we're going to say. Energy requirements for CKD stages 2 to 5 and 5D is 100% of the recommended, 100%, not less. And this could be given as usual or in the form of supplemental nutritional supports. Oral route is, but if not enough, we are going to use tube feeding. Tubes, this include nasogastric or gastrosal. Also, intradialytic parenteral nutrition may be used if the growth is not sufficient or there is evidence of malnourishment. And balance of calories from carbohydrates and unsaturated fats is important. In overweight or obese children, we have to achieve weight control. Now we come to the protein requirements. Contrary to what we are always taught, that we have to restrict the proteins in patients with chronic kidney disease. This recommendation says that patients with CKD stage 3 have to take 100 to 140% of the recommended intake, daily recommended intake. But when we reach stages 4 or 5, we have to restrict to 100 or 120 maximum. And patients on dialysis have to take 100%, not less. So it's clear that there is no protein restriction in patients with CKD in pediatrics, contrary to adults. This can be achieved through food or protein supplements. Vitamins and trace elements. Dietary intake of 100% of recommended allowance of all vitamin is recommended for stages 2 to 5 and even 5D. This is dietary intake. What about supplementation? Stages 2 to 5, if the dietary intake is not sufficient or there is evidence of deficiency, we can use the supplements. Except patients on dialysis that should receive only water-soluble vitamins. So vitamin A particularly is not recommended in these patients. Calcium is very important, and this recommendation states that the total calcium intake should not exceed 200% of the recommended intake of calcium for each, whatever the sources is, whether drugs or nutrition. Vitamin D is another story that we're going to postpone for the time and go to phosphorus. Phosphorus is very toxic, as we know, and recommended for stages 3 to 5 and 5D is to reduce that phosphorus intake to maximum 100% of the allowance, as long as the serum sodium is normal. If the serum sodium exceeds the normal, we have to reduce the dietary phosphorus to 80%. And this is very important. What about the fluids? Usually, we have fluid intake according to the amount of urine, except if the patient is polyuric, so we have to give supplemental water and sodium. Sodium supplements should be considered patients with peritoneal dialysis particularly, Otherwise, sodium should be restricted because of, particularly in the presence of hypertension. The potassium all through should be limited in all stages because of the risk of hyperkalemia. The recent guidelines about the task force presented by the task force for nutrition didn't differ a lot. It's present this year, published this year in Pediatric Nephrology. It didn't state any different recommendations concerning the energy and protein requirements particularly, but some additions in the methods of administration. What about the nutritional challenges now we are facing in children with CKD? We have to give diet that gives adequate energy, appropriate proteins, vitamins and trace elements except vitamin A, with calcium content maximum 200% of the recommended intake from all sources, low phosphorus content, low sodium content, low potassium content, and variable fluid amounts according to the urine. So with this list, you can see how difficult it would be to design a nutritional program for a patient with CKD. So what do you think if you get a product with high energy, low proteins, low vitamin A, low calcium, low phosphorus, low chloride, low potassium, and in powder form that can be diluted with different amount of water according to the fluid intake? I think this product might be very beneficial to our patients. And I am justified to give you the name because it's the only product in the market, Egyptian market now. So there is no contraindication, as we say, to say that Renastart. And by definition, Renastart is not an infant formula. It's a food for special medical purpose that must be used under strict medical supervision with regular monitoring of nutritional status and electrolyte levels. And it's not available in the market, only in university and some central Ministry of Health hospitals, and it's delivered on prescription and not paid by the patients and fully covered by the Ministry of Health. The standard dilution is like other formulas. The 20% dilution is one scoop for 30 cc's of water. This is the description of this important formula. When we are going to prescribe a diet, nutritional diet for children with CKD, we have to follow these steps. Number one, to determine the energy needs, including the catch-up if needed. Number two, acceptable macronutrient distribution ranges, the amount of carbohydrates versus fat versus proteins. And to do this, we have to determine first the protein requirements and determine fluid requirements, phosphorus requirements, and calcium requirements. With all this information determined, we can adjust the prescription of nutrition for children with CKD. Let's have a look to this case. A 2-month-old infant diagnosed with CKD at birth. The creatinine level has been rising steadily, but at today's clinic, the creatinine and the potassium have risen sharply, with potassium level now 6.6. The infant has been fed on either breast milk or standard infant formula from birth. These are the composition of standard infant formula and the breast milk which the patient is taking. But I'm reminding you that this is per 100 kilocalorie, not per milliliter. So the standard infant formula contains per 100 kilocalorie contains 2 grams, while the breast milk contains 1.35. In the special formula we are addressing today is 1.6 grams. Let's have a look at the potassium: 110, 72, 23. Phosphorus: 44, 20, 19. Calcium: 82, 35, 22. And vitamin A: 300 international units, 302, and 91. Of course, breast milk is the best, and we have to maintain the patient on it, except if he develops complication with this breast milk. So we have to introduce a low potassium formula in this case. This algorithm is somewhat complicated, going to address separately. So now we have a patient with the serum potassium level more than 6. We have to ensure that all non-dietary causes of hyperkalemia are corrected. Then we are deemed, if deemed appropriate, we can give short term of this special formula, short term only, this formula alone, with close monitoring of the serum potassium. Not only the potassium, because we know that it's low in other ions. So we have to monitor the potassium, phosphate, calcium, bicarbonate, sodium, urea level within a few hours of starting the feed. If the serum potassium becomes normal, so we have to decrease the intake of this formula and reintroduce the other formulas he have been taking or the breastfeeding. When the potassium drops between 3.5 and 5. So it can be used only for short term with monitoring, good monitoring of the electrolytes. If again the potassium is increased, so we can reintroduce the formula. Another is a 3-year-old child. The other one was 2 months old, was an infant. This is 3-year-old, so this is a child. This formula can be used up to 10 years of age. His 2 years have been diagnosed with CKD for 2 years. Creatinine has been slowly increasing over the last year with a steady but sustained rise in potassium to a level of 5.3 at the clinic today. It's just above normal reference rate. This child has a supplementary tube feeding of standard pediatric enteral feed, providing 50% of energy requirements. He takes small amounts of low potassium foods throughout the day. So now, this algorithm, the patient has serum potassium level between more than 5 and 6. We can change the formula he's taking by adding quarter of the special formula and 3/4 breast milk or standard infant formula or the standard pediatric enteral feed he is taking. With this ratio, we are going to monitor again 24 hours after changing the potassium, phosphate, calcium, bicarbonate, sodium, and urea levels. If the potassium is back to normal, so we again continue on this dietary management with again monitoring, and then the proportion of the special formula in the total feed can be adjusted depending on the serum potassium level. If not, then increase the concentration of the special formula, half and half, and even more. And in some cases, if we reach the potassium level above 6, we can use it alone for a short period, again with continuous monitoring of the serum potassium level. If the serum potassium, as I said, will continue to rise, we can increase the concentration until it becomes normal and continue monitoring and then reinstitute the other formula he was taking accordingly. Another important point with this formula is the comparison with the whole cow milk, because as we said, in children, they are receiving other foods. They should be low in potassium and phosphorus, but cow's milk is an important source, particularly in young children. So if we compare the standard dilution with the cow's milk, it's low in protein, better in energy, low in potassium, far below in potassium, phosphorus, and calcium, and vitamin A. Even if we need to increase this dilution or to increase the concentration, I mean, because of the amount of fluids that we should give, we still are far below for the cow's milk for the potassium, phosphorus, calcium, and vitamin A, but not vitamin E. So this is another important point with this formula, that it can be adjustable for the concentration. This is the example of the combination of the formula with the standard infant feeding. So if we can see this is 50-50, the amount of protein is not much increased, the energy is stable, the potassium is again lower than the formula alone, the phosphorus is low, and the calcium is also low, even in the 50-50 dilution. So the flexibility with this formula is important to us. In conclusion, nutrition is an integral part in the management of various renal disorders. Nutrition in CKD patients is a special challenge that needs a close cooperation between our colleagues, nutritionists, dietitians, and nephrologists to achieve a better quality of life for those poor children and to prevent and treat many complications of CKD. Such a team is mandatory for the success of any center who provides care for CKD children, whether on dialysis or not. Parent education is essential for the success of any modification in the child's nutrition. It should be done by a professional, well-trained dietitian, something we are unfortunately still lacking. Any profession needs tools to perform its function. Even the medical profession needs its tools. And for the nutrition, these are our tools. And addition of new tools will help us to achieve better goals. Thank you.